Well, hello, good afternoon. We're a couple minutes behind waiting on a few people to come, but we'll go ahead and get started. My name is Ryan Beatty. I'm chairman of the Sedgwick County Commission alongside my colleagues here. You got David Dennis here, Commissioner Jim Howell. I want to officially welcome you today to a leadership meeting that's going to be focused on the topic of intellectual and developmental disabilities and mental health. For those that have been working in this space or have familiarity with this topic, you know that this gap in services between IDD and mental health is a very complex problem, and it's a growing problem. There are some enduring questions that we have that really surround this topic. Questions like, well, who does what? Where's the funding? Who's the appropriate funding source? What's the impact of these services if they're not being met? And ultimately, what are the real sustainable solutions? These challenges are real. And that's why this discussion is so important. So ultimately, what happens when we have big community challenges like what we're facing here? Well, at the very least, we do what we're doing today. And what happened a few months ago is we come together. We don't dodge these challenges. We summit for progress. We gather, we advance ideas, we advance strategies. We try to glean from work that's being done across the country, and then we explore, what could we do here and what is the opportunity? I think it's really important too that we have to keep the underlying theme under this whole discussion. The underlying thing we have to never forget is there's a lot of people in communities all across this state, and especially here at home, that are really desperate for improved outcomes. They're desperate for it. So this work and some of the things that we're embarking on today, it has significance and significant importance. So I want to thank you from the commission. I want to thank you from Sedgwick County government. I know Annette and her team will be thanking you as well for your commitment into engaging conversations that improve systems and help to impact some of our most vulnerable neighbors. I want to briefly, since I got the mic, I'm going to share three things this morning with you very briefly. And I want to help paint a picture of what's happening in this community so that we have a canvas that we can work from. But also, I also want to remind us of some things that we've been doing here the last few years that are building up the behavioral health ecosystem here. Some successes that we're having now and successes that we are envisioning in the future. It's just three quick things as reminder. Number one, some of these exciting opportunities we have brewing. The first is that we have a biomed campus coming just south of here. Upwards of 3,000 med students and staff. Thank you to the state. Thank you to Wichita State, KU, all of those that got involved in this, that this is going to help us with a significant pipeline need for staff. We have a mental health hospital that is coming here. And again, a state mental health hospital, a lot of conversation, a lot of partnership. Not only will it's going to relieve tension from Mr. Easter's jail, but it's also going to help those that are in desperate need in this community. We have a ComCare crisis expansion coming that will have expanded services, expanded opportunities to meet a growing need in this community. The city of Wichita has a multi-agency center dedicated to meeting those homeless individuals and the needs that are happening here. All of these things are happening right now. Many of these things have been discussed for the better part of a decade, and they're happening right now. This four-legged stool in this community is building something that I believe will be the gold standard nationally for how a community comes together to collaborate on some of our biggest needs. I believe it to my core. These things, you couple these things with significant economic developments happening here, and you have to admit that there's a buzz in Sedgwick County. There is an energy here, and there's work to be done to help prepare for some of this growth. So let's talk about, those are some of the good things we have. There's also, number two, there's some challenges too. And we can't bury our head in the sand on some of these challenges. Let me remind you that 80% of our students in USD 259 live under the poverty level. We do have a housing shortage that we're trying to quantify with research and academics and studies, but we have a housing shortage here that's really putting a clog into some of the things we're trying to accomplish. Substance use is ravaging our community in many ways. The opioid epidemic, fentanyl, the types of meth that are impacting this community today, it's different and it's hurting our families. Homelessness, where we're seeing people have public crisis right before our eyes, is really getting to the soul of who we are here. And it's really jolting us into action. Foster care, I thank you, Dee, for being here. Foster care, there are approximately 1,400 kids here in Sedgwick County that are in out-of-home placement. 70% of these kids will have a touch point with the criminal justice system. Only 40% are going to graduate high school. 1 out of 4 will find themselves homeless within 2 years of aging out of the system. As you know, the state has made progress on the waiting list, but there's still a significant waiting list, upwards of a decade. And even the questions are, even if we are able to make more progress on the waiting list, do we even have the bandwidth here locally to support more people coming off of the waiting list? Which are complex challenges. And if we could pull a lever and solve these problems, some really smart people long before us would have probably done it. They're hard. There's multiple determinants influencing these outcomes, and making progress on these things are incredibly challenging. So the last thing, and this is really a message to some of you that are providers in this space, but to all of us really, 3 simple words is that we need you. We need you. We need your ideas. We need your heart. We need your mission. We need your investment. We need your brains, and we need you in a big way, and we need you now. See, the backbone of our economy, the engine of our workforce, is actually built on the backs of healthy people and healthy families. In this community, whenever we've had challenges, we have always come together with leadership and solutions to meet the need, to stand in the gap and deliver. And in my view, I think this gap between mental health and IDD, this gap, this growing gap, is one of those challenges that I think that we are morally compelled to stand in the gap now and meet this need like never before. So today, in meetings like this, they mean a great deal to us and a lot of people in this room. We just want to thank you for being here. Thank you for engaging this topic. I want to welcome you here this morning to Sedgwick County Government. So who's next?
I'll take it from there.
She's got it. Thank you again for being here. Enjoy lunch.
Thank you guys so very much. I cannot tell you how much I appreciate it, Commissioner Beatty, and all the attention you have provided to this issue has just been so heartwarming. And I'm so excited to see everyone here. Thank you so much for coming. We had no idea we were going to generate this amount of response to our invitation to come together on this issue. We do have consultants that are from out of state. And so I know your title is on the name tent, but it's a little small. So if we could just go around the table real quick, just introduce yourself and your role. So our consultants will be able to put a name with the face and your position.
Yeah,
Regional Director for the Wichita.
Matt Fletcher with InterHab. It's the state's provider association.
Yeah, Randy Ryder for the District County Department of Aging and Disability.
Hey, Dan, I'm Commissioner District 3, the best district.
And I'm Ryan Beatty, County Commissioner for District 4.
Jim Howell, County Commission, District 5.
Chase Blizzy, a member of the state senate for representing the western half of Sedgwick County.
Lee Cat, Government Affairs for the Kansas Department for Aging and Disability Services.
Scott Abraham, Deputy Secretary for Hospitals and Facilities for the Clearance. Katie Brown, the Deputy Secretary for Programs of the Kansas Department for Aging and Disability.
I'm here with and I'm the IDD and control crisis stabilization.
Aldona Carney, parent guardian to a young man with a dual diagnosis, be 30 in December, and I'm also on the Starkey board.
I'm Jim Henry, Director of Mental Health here. And I'm the manager of the Rural Health.
Senior Vice President, Utility, Cambridge Children's Hospital, Cambridge.
All right. Thank you so much. And Travis gets the award. He came from Kansas City. So I think he came the furthest. And I don't know if I introduced myself. I don't remember now. I was carried away with all Commissioner Beatty was saying. Jeanette Livingston, I'm the Deputy Director of the Sedgwick County Developmental Disability Organization, part of the Sedgwick County Department on Aging and Disabilities. And it was so great. You encapsulized so well, Commissioner Beatty, all the awesome work going on in the community, specifically around mental health. And it's been so awesome to see that this important issue is getting the attention it deserved. Today, I just want to focus on a subset of the population that do have mental health needs that may not have come to your consciousness. But it's been a big issue in the intellectual and developmental disability service system. And I'm going to abbreviate that and just say IDD. It's probably way before the CDDO and may outlast us there, but we've been working for many years to try to help individuals that have IDD and co-occurring mental health diagnoses. In fact, some of the work, Dee, when you were here, you were behind some of the groundbreaking work we did on trying to assist folks with these complex cases. Dee served on a work group both here locally and at the state. She brought a specialized training for mental health clinicians to the community. And the CDDO was the first in the nation to do a SIMS for the disability population. And that's the sequential intercept map. It helps us identify areas to target for co-occurring conditions for, in this case, IDD and mental health with regard to law enforcement interactions. And despite everything we've done over the years, I would say that we've never quite had the impact that we would have liked. There's always more that needs to be done. And I think some of the people in this room can certainly testify to that fact that we don't have it right at this point. So I was so excited when the legislature allocated funds specifically for this issue. And then KDADS very nicely gave us a grant to help address this issue. We quickly identified START as an evidence-based or evidence-informed model that other states have used to effectively target this issue, this complex issue. So we contracted with the National Center for START Services to do an evaluation of our community mental health service system and how it works for folks with IDD. The first task we were given was to gather data. And so we have an existing relationship with the jail. We have staff that actually follow folks that are in the IDD system that happen to be incarcerated. So I pulled the report for 2022. And we had 24 individuals in jail in 2023. I say 2023, which is not huge in the scope of the jail's population, but it was immediately clear that they had a much longer stay than the average person that happens to land at the jail. In fact, we had out of the 24, there were 9 reoffenders that accounted for the majority of the incarceration days. We ran the report in August of 24, and there were 4 people that were still in jail that had been arrested in 2023. And so, honestly, we don't have the same amount of data for hospital stays, but we know that's also a problem in the hospital, that our folks with IDD kind of get stuck there for longer periods of time than we would like. Next, we collected data on emergency response. So we looked at the 214 sites that are either IDD provider owned or operated. And there were 1,361 calls in the calendar year of 23. 805 of those were law enforcement. The majority went to just 28 locations. And while not all of those calls would be mental health crisis related, from our critical incident reports, we do believe that most of them probably are. And we had one group home that had 80 calls in that 1 year. So one group home. So they usually have, 4 to 6 or 7 or 8 people living there, had 80 calls. Internally, we were all really shocked with that group home because it was one of our providers that has really stepped up. They have invested in trying to serve this difficult to serve population. The IDD system, we're very fortunate to have regulations that do not allow services to be offered or provided in a way that discriminates based on an individual's disability. And as the CDDO, we take that responsibility of enforcing those regulations very seriously. So we have conversations with providers all the time. We know that it's difficult, but you still have to serve the individual. You can't turn people away. And we have a diverse network of providers. And so we have, some providers that have really taken that task and geared up for it. They have invested in staff training. They have hardened homes. They have purchased the vehicles with the cages in it. And then we have other providers that maybe have not taken up that same responsibility to the same degree other providers have. So the fact that we had 80 calls at this group home kind of emphasized, at least to me, that we have room for improvement. We definitely have room for improvement, even in the best of days. So I could go on with facts and data because that's a lot of what I love to do. But the one thing the START staff asked me to do was to provide a case study. And it was harder than I thought to provide a case study, not because we didn't have a bunch of them, but because they all ended with, and then they went to Parsons. And I thought, that's not the outcome I want. I want to keep them here. So I found this case study. And it was about a young woman. She was age 18. Her diagnosis were moderate intellectual disability, autism, fetal alcohol syndrome, disruptive mood dysregulation disorder, post-traumatic stress disorder, and ADHD combined presentation. So she had a long history of violent behaviors, self-injuries, suicide attempts. She was in DCF custody, so she was in foster care at the time. She had assaulted her grandmother, and that's what she ended up being in DCF custody. She started services in the IDD system in 22. And so shortly after moving into her group home and receiving residential supports, she attempted to strangle herself. And so, law enforcement or EMS was called, and she was taken to the hospital, put on her 72-hour watch, released back to her home. Next, she eloped from her home, ran out into traffic, staff trying to get her to safety. She assaults the staff. Police arrive. She's taken to the hospital, 72-hour hold. Okay, so this pattern goes on again and again and again, and she attempts suicide. She tries to cut herself. She attempts overdosing. She, cords around her neck, time and time again. Eventually, the hospital, rather than the 72-hour hold, they began saying she's having a behavior. Take her back to her IDD staff. They should know how to manage this. Sometimes police would show up. They might do some, de-escalation techniques, and they wouldn't necessarily take her. But it was a total of 17 other times that she had these same sorts of behaviors. The final entry in that case study was when she took a rock and pummeled the staff person's car, breaking the taillight. And that one ended in an arrest. And this is not a perfect case scenario for you to have in the back of your mind as START goes through. It doesn't really tell you who she is. You don't understand what her background is necessarily. My first thing that came to my mind was, is she from Sedgwick County? Because boy, do we tend to attract folks with the very severe behaviors. Places other have not been successful, so they tend to migrate to Sedgwick County. And I don't know. Then I think we can assume she had a difficult start in life. She had the fetal alcohol syndrome. She was being raised by her grandparent. Probably also had some significant trauma history with the PTSD diagnosis and being in DCF custody. So hopefully the case study gives you kind of like a face to put with the numbers that the START staff are going to share with you. And I'll turn it over to them, and I'll let our folks from the National Center for START Services introduce themselves to you and get started with the presentation.
Hi, everyone. My name is Luke Renard. I'm with the Center for START Services at the University of New Hampshire. This is Ann Klein. She's director of our data outcomes, manages a national database, and then we're both also serve on a research team that studies issues with intellectual disabilities and mental health. One of the reasons we asked Jeanette to talk about a case study is that Ann and I are going to go through a lot of statistics and data, and then we're going to talk about money a little bit. It's easy to lose the people in those conversations. So I think it's important when we go through this information that there's people behind every single one of those numbers. So I don't want to lose that in the context. Does that make a little bit of sense? So I should also mention it was 11 years ago when I was sitting where you were. When we were doing this in Fort Worth, Texas, and START came to town, and we were struggling. We didn't know how to meet this need, and I was where you were, and we adopted a program, and we'll go through some of the Texas outcomes too. So our goal for today, we want to provide an overview of what START is, and then how might that complement what you already have in place in this community. And then we'll talk a little bit about some data projections and some potential cost savings, and really what Ann and I consider the greatest benefit is really the opportunity costs that you're going to gain should we choose to move forward. So I also I know we're live streamed and everything, but this should be interactive. So I would invite you to interrupt me if you have a question. We will leave time at the end so we can have some discussion. But if you have a question or a comment, please stop us. That's okay, and we'll talk about it.
If I can just add quickly, since we are live streaming, if you do have a question or a comment, just if there's a mic around you, hit that button before it turns green so that the people that are listening in can hear us as well.
Okay, good. Thank you. So first, we got to provide some context. So what is START? So START is an evidence-informed model of serving people with intellectual disabilities and mental health needs. It stands for Systemic Therapeutic Assessment, Resources, and Treatment. Dr. Joni Beasley is the creator of the model back in the 80s. She was the founder of the center at UNH and now is a research professor. So she has moved out of the operational phase and is directing research now. We are now in 31 states in some form or fashion. Some adopt a full, we call it a START model of services, so a full START program. Others have professional development, some have training, some do just consultation on what would a best practice look like, system design. So it's a number of different things. And at the end of this, in a few months, we'll have all of our data collected and we'll present a final report with some recommendations on what might be the best fit for Sedgwick County. So as a research institute, we study a lot of kind of foundational data, some outcome data on disparities with people with IDD and mental health. What we know, mental health is health, right? Your head and your body, they're very much connected, even though a lot of systems don't treat them the same way. There's a lot of people, and I guarantee it in this community, that do not have formal diagnoses, that are still sitting in your jails, that are sitting in your ERs, that we're not collecting the data on because the formal diagnosis isn't there, but I guarantee they're here. What this typically tends to result in is that we have a population that remains underserved, remains in a constant state of crisis, and we're not talking about just the people, we're talking about their families too. So the people that support them, related or not, isn't just an individual effect. This is a community issue. And ultimately, those are going to strain your resources, and you're using a higher level of care, a more costly intervention to kind of serve a unique need. And we think we have some ideas where we can maybe approach that a little differently. And then, not to mention, again, going back to the case study, is that this is about a quality of life measure too. Right. So people in these situations, it's not fun to sit in an ER. It's not fun to sit in a jail cell. There are different ways we can approach this and improve quality of life for families and for individuals. What we do know, although the research is a little all over the place, but it's pretty well accepted that about 35% of people with intellectual disabilities and autism have a co-occurring mental health need, whether that's a formal diagnosis, kind of an incident, but that's for research purposes, 35% is an acceptable statistic and pretty accepted across the board. This is compounded by kind of the social issues that go along with that. So you have your isolation, bullying, Of course, the social determinants of health that just aren't there. There's lack of community involvement and engagement. Ann and I were with one of the provider agencies this morning, and a lot of our discussion had to do with purpose. People need meaning in their lives. They need a reason to get up. You know, they need a feeling of belonging. And I think that's often missing in some of the fragmented systems. We talk a lot too at the Center for Start Services about diagnostic overshadowing, right? So Jeanette's example, this person goes to the ER. The doctor says, no, this is not a mental health issue. This is just their IDD. It's a behavior. So despite overwhelming evidence, there's still a lot of people that don't recognize that you can have both. You can have an intellectual disability, you can have a true mental health issue, and you can actually work with both. The best way to conceptualize how START works is the public health model. So I don't know how many people are familiar with this, but this is a tried and true graphic that shows the impact of levels of care. So your best chances of impacting any population are the top of the triangle, right? This is where you have the most options available. You can serve the largest scale, the greatest number of people at the lowest cost per person, right? So this is if every car had seatbelts, that's an easy, cheap intervention, right? So that's where you want to start. How much proactive work can we do for the greatest number of people at the lowest cost? As people fall in the triangle, you start to lose options, right? So if you're not doing that proactive work, then you have to be more responsive. You're not responsive to a population, you're responsive to a person or a group, right? So your costs are more, your resources become more intensive, and you're actually influencing fewest people. We get to the tertiary intervention, which is where you're dealing on the one-on-one situation. Your police officers are going out, 3 people to 1 person call. That's a very expensive intervention. How many people are you helping? You're helping 1, right? So your best use of resources is what can we put in that primary level? So, and this might be a little clunky because Ann and I are actually gonna, based on what we do for this center, we're gonna swap out a little bit. So I'm gonna turn it over to her and then I'll be back up in a bit. Right, here's the button.
I'm a data person and we usually work in basements and don't get out much. So I'm a little nervous because I'm doing some of the slides for Karen who couldn't be here today. So we define crisis as a problem without the tools to address it. And so crisis can happen in family homes, they can happen in residential programs. It's any place where there aren't tools in place. So in a program, it might be training, it might be experience. And when that happens, people need someone to call who does have those tools. And based on the work that we've done in Sedgwick County so far and what we heard from the commissioner this morning, your system has a lot of good tools. So you have CIT trained officers, you have an ICT team, you have the 988 rapid response, and START doesn't replace any of these services. Rather, START's a linkage model. And the goal is to partner in the community in 2 primary ways. And so the first is on the prevention piece, and I'm going to talk about that on the next slide. And then the second is that when a crisis does occur, to get interventions that can quickly get people back into their homes and in the community. So a fundamental goal of START is to increase the capacity at every level of the system, but especially at that top level that Luke referred to. So we want to be able to train folks across the system to respond in a crisis and to respond effectively. And then when people do need those higher level supports that are at the bottom of the triangle, that we want to get people out of those supports quickly. So I have one data point here, and I'll share some more in a few minutes. In 2023, nationally, we responded to over 2,700 crisis calls. 21% of those were handled via telehealth at what we call the stage 1. So this is a crisis was brewing, but it hadn't really escalated to the point where they needed in-person intervention. We still had 21% of crisis contacts that required law enforcement support. So, we always want people to be safe. And I'm going to talk about crisis plans. Every crisis plan says if the person is an imminent threat to themselves or someone else, we need to call the police, right? That people need to be safe. And then 70% of those interventions were able to prevent a higher level of care. So in some cases, this means that people could stay in their homes. In some cases, it meant that they could go to the ED, get stabilized, and then go home. So they didn't get stuck there. They didn't have to be admitted to an inpatient place. Okay. So I'll take a step back now and talk a little bit about prevention. So START is designed to be a time-limited service. So this isn't something where you're in START and you're in forever. It's usually 18 to 24 months, and it works very closely with the existing support team. First, to stabilize people who are at risk of emergency service use, and then again, to build capacity within that system to maintain stability. And when we talk about support teams, this is a really big umbrella term. It's inclusive of families, it's providers, it's the mental health system, it's employers, it's anyone involved with the person. And the goal is that all of those folks in the person's life and also the person themselves is going to develop those tools, right? So again, going back to the definition of crisis, it's knowing what to do when you have a problem. A key part of that is the comprehensive cross-system crisis plan that every person enrolled in START has. And this really teaches people to understand the warning signs for crisis and what can be done to kind of prevent them. So we really focus a lot on what does this individual look like when they're doing well? And then what does it look like when they start to not be doing well? And to try to get some of those interventions at the early stage before it becomes a full-blown crisis. START can do that. They also have 24-hour-a-day telehealth response and then in-person response if something does escalate. And again, sometimes that involves people staying in their homes, and sometimes it involves other responders or emergency services. So when those services are needed, the goal is, again, to get them in and out. So people get stabilized and they don't get stuck someplace. And I do want to mention here, and Luke will probably talk about it a little bit later, resource centers. This is an optional component of START that provides a subacute level of care. It's usually 4 beds. It can be a standalone place, or it can be combined with another acute stay provider. And it's really meant to be a bridge between the hospital and the community. So this could be for folks who are stepping down from a higher level of care. It can also be an alternative when somebody is in crisis and it may not be safe for them to stay with their family or in their group home for a short period of time, but they may not meet the need for inpatient care. And these are secure facilities, but they partner with community coaches, and that these are coaches that make sure that whatever is happening in the resource center can be translated back to the person's home. So one of the things that we often hear is that when folks are doing well in a really structured inpatient settings, sometimes some of that doesn't translate well into the community, and then it becomes a revolving door. So again, it's about that kind of capacity building within the system, and this is one alternative for that. So kind of who's at risk? Again, there's people behind all of these, and many of you probably know who these folks are in your community. But we're talking about people who have frequent use of emergency services, people who are in higher levels of need for residential and day supports, people with staffing enhancements. So people who need 1-to-1 staff or 2-to-1 staff to be safe in their homes and in the community. Those are the folks that we're talking about. We're also talking, though, about the folks that you're worried about. So the folks in your system who have multiple mental health diagnoses, the people who are taking a lot of psychiatric medications, those are the folks that also make kind of good candidates for this type of intervention. Okay, I think that's it for me for now. I'm going to come back and talk about data in a few minutes.
So, we talked earlier about, mental health is health. From a statistical point of view, people with intellectual disabilities or autism have a number of medical conditions that make even serving this population either more expensive or more complicated, and those have to be taken into care. So START is a holistic model, right? This isn't a let's get you sick to being back to normal, right? So this is let's see you thrive. So we address a number of different things. But that's one thing as we're going through this, that this is a complicated approach. So just keep that in mind. One of the things I was excited about when we heard who's coming to this meeting, a lot of times when we talk about START, maybe we're meeting with a hospital. So a hospital is worried about their budget, their doctors, their nurses, their ER. A room like this, we have so many different people represented. You all care about every bucket. You care about Medicaid costs. You care about hospital information and budget. You care about your officers. You care about who's sitting in the jails, who's being prosecuted. So you have your eyes on all the buckets. And I think that's where you're going to see the greatest impact. It's not we're going to save millions of dollars for the hospital alone. What you're going to do is find a downstream impact across a number of different funding sources. They're going to make this more economical in the long run. So we're going to sprinkle several different real world examples where we have seen implementation, we've seen cost savings, and we've seen improved outcomes. Tennessee is a good place to start. This particular TennStart was a program back in the early 2000s. It folded, it was unfunded, I think in 2012. And then in 2018, they came back, and now TennStart actually covers the whole state, and it's funded through their managed care system. Again, as a research institute, what we did here is we did some matching. So we took 15 people in the Tennessee START program, matched them with 15 people with similar backgrounds and diagnoses, and then looked at the data over a year. So what you're seeing here, and I apologize for putting up too many numbers. I know that's sort of a no-no in a slideshow, but we were talking about money, so you got to. What you're seeing is, so the two right columns are people that were not enrolled in a START program. These are people that were getting services from a provider. Typically in Tennessee at the time, ABA was applied behavior analysis was their method of serving people, which we know a lot more about effectiveness on ABA, and it's much more effective in younger people than it is in adults. But at the time, you can kind of see the difference in community-based costs. So average of emergency room visits, psychiatric hospitalizations, the police contacts, that's a big difference. The arrests, incarceration days, and I can let you know the incarceration days are somewhat skewed because it was one person, and he actually had to have a higher level of care at the end of the study. But you can also see the respite days that were required to give relief to families. And I think one of the interesting data points here, if you look at the crisis contacts, right? So those are the same. So even though you have the same number of crisis contacts, people will go into a crisis. There's two methods of responding. People involved in Tennessee START, their crisis response was from the START team. The people not in Tennessee START, their crisis response was from law enforcement. But what you see, regardless of who responded, the outcomes were still better for Tennessee Start. So it shows you that the method of responding was kind of the differentiating factor. You had social service response rather than law enforcement. And this was before widespread CIT training, things like that. When we look at the actual cost of enrollment at the time, people receiving Tennessee Start was a little over $4,000 per person. Again, we're looking at almost 20 years ago. Non-START people, again, primarily behavior analysis support, about 3 times that. So you can see this is a real world example where a community was becoming more efficient and people were getting better outcomes. This is again, I want to give you this is a real life example. One of the, like I said, Ann manages our national database. So every START program across the nation it's very data heavy. So they put in all sorts of different factors into our database. So we're able to look at things nationally. And we have several real world examples, and we picked ones that we think apply to this community. This particular example, we picked for 2 reasons. One, it is extreme. However, what we find is, although this is extreme, every community has at least a few people that meet this same definition. And you probably can name the top 10 high utilizers in this county. Because regardless of what you oversee, they rise to the top in that particular segment. So this person, again, from the last few years and is a real life person, she's a 25-year-old woman. She gets residential services, aggression, self-injury, which are aggression is our #1 referral source, by the way, to START programs. She has a bipolar diagnosis and PTSD. In terms of trauma, that's probably the #1 presenting problem. As people come in with a history of trauma. Prior to her enrollment, she had 70 ED visits for mental health conditions. She had 50 plus inpatient admissions. I mean, I don't even know when she was in the community. I mean, she must have gone out the door and went right back. What we do know, since 2021, when she's been enrolled, she received very intensive START services. This is not a typical person that might be enrolled in START, but it's a distribution, right? So you have 2 ends of the spectrum, but this is someone that we would absolutely serve in a START program. They get intensive outreach, a lot of contacts. They get a crisis plan. The crisis plan is not for the individual. The crisis plan is for all of us around, right? So what are the police going to do? What is the hospital going to do? What's the provider going to do? What's the therapist going to do? We're the team surrounding that person. And that's who the crisis plan is for. And if this happens, here's what we're going to do. So although a very, again, extreme example and got very heavy START services, just based on some aggregate and national statistics, we estimate that just her ER and inpatient use was over $300,000. We looked at the actual START cost, and her START costs were much higher than typical. They were about $25,000 a year. Most teams are half that. Either way, this team saved the system about $200,000 just on this one person. And again, extreme. But I'm betting there's a few people that are similar to this young lady. Kind of talking and building on this opportunity cost approach. Across the nation, we typically see very similar outcomes in communities, and we know that after implementing START, you're not going to see anything the first year. You're going to have relief in the system. You're going to have another person to bring onto the team and to shift some of that work to, but you're really going to start to see your economic outcomes after 3 years. And that's when your ER services are severely reduced. Jail prevalence is much, much less. Police response, they have someone else to call. There's another option. And I know you have a good ICT infrastructure. You have your crisis response at ComCare. This is a team to bridge that. Even when we were meeting with those people, they'll go out and respond. Then what? And they didn't have that bridge person to kind of pick up that warm handoff and move forward. People enrolled in a START program, they would respond directly to that person. So you wouldn't have that duplicative kind of overlap. We also see that people have reduced institutionalization. Families feel better supported. People have better outcomes when they can stay with natural supports. I mean, that's not even up for discussion anymore. It's just an assumed fact. If people can stay close to family or natural supports, they have a better quality of life. And then I think one of the biggest things we see is this reduces strain on other pieces of the system. So you have your service coordination and your case management units. They feel better supported. In part of START, when we talk about the top of the triangle, one thing that the START programs do is provide community training. It's one of their core components. It's not just their intensive case management. It's an educational piece. And your START team doesn't just serve one provider. It's like your fire department. They serve everybody who needs it. So the whole point is to, the rising tide approach, right? We're going to get every provider more competent, more confident in serving these challenging people. We'll get in, do the work, and then fade out as people get better. Oh, now we're back to Ann. Back to the data.
All right, so I'll share a couple of data points from START programs nationally, and then more importantly, we want to try to kind of describe what this might mean in Sedgwick County. So the START model, as Luke mentioned, is an evidence-informed research and evaluation model, so we collect a lot of data. And a couple of the outcomes that we measure for every START program are crisis disposition. So what happens when we respond to a crisis? And another is around emergency service utilization. So I had this up before. In 2023, we responded to over 2,700 crisis contacts. 81% of those calls, the person was able to be stabilized and maintained in their home. Nationally, we served over 3,500 people in 2023, and over, 72% of them, I think, had a decrease in the severity of their mental health symptoms. And that's as measured by the ABC, which is a validated assessment tool that all START programs use. So this is a graph that shows the overall reduction in emergency service utilization for START enrollees nationally. So this is longitudinal data. It's the percentage of START enrollees who had used either the emergency room for a psychiatric or behavioral reason, or had had a psychiatric admission in the year prior to their enrollment. So that's a data point that we collect at enrollment. And then what we have is the percentage of people who used one of those services post-enrollment. So it's not a perfect measure because we're measuring people for a year prior, and then most people are in START for more than 12 months. So maybe 18 to 24 months. So, but even when we adjust for that time variable, we consistently see double-digit reductions in emergency service utilization for folks as early as 12 to 18 months after programs are implemented. Okay. So, kind of what does this mean on the ground? In Sedgwick County, we looked at some of your data. There were 71 hospitalizations for folks that were served by the county, and that was at an average cost of about $25,000 a stay. More importantly, and I know it's a little small, but the recidivism rate for folks was 47%, and it's even higher for emergency room visits. For START nationally, our inpatient recidivism rate is about 19%. So even a moderate decrease in that number is going to translate into a cost savings. And I'm going to talk about kind of the combined cost savings in a second. This is crisis call disposition. And you can see the disposition. We have the vast majority are able to be maintained in the community. We have a percentage that goes into the hospital or the ED, sometimes into other crisis stabilization programs. And then all other are folks that may be incarcerated, maybe have a medical admission. So sometimes we have a crisis contact and it turns out the person has acute appendicitis and that's why they're having a really hard time. They have a toothache, yes. And so they're able to be stabilized medically and then the crisis goes away. So that's what's kind of in that all other. But what I want to kind of take a look at is crisis response from START and in Sedgwick County. And particularly if you look at that 67% where the police responded and were able to leave the scene. So that means law enforcement responded and were able to stabilize the person in their home, right? Which is kind of what we're talking about. And what that means, and I don't have the, I should have put the ends on this, but it was well over 200 calls. That's 200 potential calls that maybe law enforcement didn't need to respond, that maybe they could have been stabilized without law enforcement, maybe not in all of them. And so that's 200 opportunities where law enforcement were doing something else, right? So they're not responding this, that means, they're out in the community doing the other work that needs to happen. So I think that's kind of an important, data point to keep in mind that there's this opportunity in the system. The other thing I want to talk about is the incarceration. So START nationally, less than 1% of our crisis responses result in incarceration compared to 7%. And again, these are not huge numbers, but for people, for families, for individuals, not going to jail is, often a good thing for people who have IDD and mental health issues. So let's see. Incarceration days, we looked at the, total incarceration days and what even a conservative decrease in those might mean. And then again, in police response avoidance, those are some bigger numbers. Now, none of these numbers in and of themselves are huge, right? We're talking about one county, a relatively small population of folks that fit into this. But the savings isn't just monetary. It really does have that cascading benefit to the whole system. So again, every time the police don't need to respond, that frees up their time. Every mental health bed that isn't taken by somebody with IDD who's completed their active treatment, but is still there because they don't have a place to go, that frees up a bed for somebody else that needs it. Every hospital stay or ED visit where that length of stay is decreased a little bit frees up that space in your system. So there's a lot of kind of opportunity costs by serving people in these less intensive services. And then again, all of this is less trauma. I mean, for folks with IDD and autism, flashing lights, beeping machines, loud emergency rooms, those are never like the best, are often not the best places. It's a lot less trauma for people. It's a lot less trauma for the individual being served. And also, there's just also some risk avoidance if you can have folks that are being served by mental health professionals.
What if it's determined by the START team that the person that's in crisis needs a med wash? Is that something that can be done within the START house or the community?
It can. So in certain cases, we have. Of course, we would be working with medical professionals. They would probably do the changes in some sort of inpatient setting. The value comes in is, let's say they do the change. We would provide that next 30 days. The person could be in the resource center. We're doing observations, the doctor's coming out, and we're doing that together in a controlled environment. We're going to have 24-hour support. So we've done it in the past. It's not uncommon. But it's, again, it's that partnership. We want that psychiatrist or PCP, whoever, we want them there every day checking in too. So, but yeah, it's very doable.
That might be it for. Any other questions about? Okay,
Follow-up question
Yeah.
to Aldana's question. You mentioned resource centers a couple of times. I'm curious how those have been developed in other states. Are those private providers? Are those state-run facilities? Are they county entities? What, can you describe those better?
so just to be clear, START does not provide any direct services. Any services get provided by providers in your community. So the vast majority are private provider operated. And then they work with START and we provide the training and the consultation and the data collection and all of that. And you've operated some, so you're going to be a better person to answer that. But yes, they are run by providers.
Yeah, it's a good question because there's a couple ways to do it. So our role at UNH is to provide the training consultation. It would be up to your county to is it going to run through ComCare? Is it going to run through CDDO directly? So we've seen units of local government operate the program directly. That way it's unbiased, right? So all providers feel that no one's going to steal their clientele that way. So there's the benefit of having a unit of local government do it. A lot of communities choose to RFP it out, right? So then the private provider would bid on the contract. They get trained, again, serving the entire community. The resource center is operated by the same team that's doing it, whether it's through CDDO, ComCare, or a private provider. It's a component of the team. So you have your clinical group that's going out doing the intensive case management, the in-home coaching. Your resource center then is your physical. It's typically a 4-bed site. We like to do 2 crisis beds and then 2 planned beds. The planned beds would be for families that know once a month their son needs a break and they need a break. It reduces tension and it's a therapeutic stay. This is not respite where we watch TV. We're working on skill building, coping, and things that translate to back home, right? And then as people go back home, we follow them. We send one of our coaches in and we work with the family or the group home staff. But that's also, when we did this in Fort Worth, we used actually an old ICF home from the 70s that was no longer in use. And it had 4 bedrooms on one side and then had a second half that was like for an live-in provider. And that's where actually we had our office out of there. So it was one big hub of activity. But that way your coordinators are interacting with your coaches who are fulfilling parts of the plan. So it can work, like it can be flexible on the needs of the community. But our coordinators would know, they'd go out and things are in a tense state. They would say, you know what we need right now? We need a planned resource center stay. Let's work on your admission. And this isn't one of those things like, let me submit an application and the boss will approve it. This is important. So let me help you get it and let's start packing. We're going to get you in within the hour.
Could I ask a follow-up if it's okay? What happens now in the community, it might be better for other people to ask that are providers here. What happens now when a crisis stabilization is needed? I know there are multiple times in one of the homes with Starkey where there's an IDD, dual diagnosed mental health crisis happening. And all some of these house leaders are saying is we just need to get them stabilized, then we can get them back. But they have nowhere to put people for a crisis stabilization. So what happens now? What does that look like now for the dual diagnosed folks?
Well, it varies. Sometimes they try to go to the emergency room and sometimes it's that overshadowing kind of diagnosis. It's like it's not mental health, it's an IDD issue. And so you go back home. And so sometimes they get hospitalized and then they go back to the community provider. Sometimes we try to work with the state to get Parsons State Hospital admission, but there's a waiting list there. So that's why we're having these meetings, because there's not this kind of
prescribed plan.
There's not a step down model. So that is the issue, that You know, there are times you can't get them into the hospital. They get stuck. What do they call that? Boarding.
Mhm.
They get boarded in the emergency department until they can move them back to the facility, or they go back home. And then those issues aren't addressed. So the START model is great because it provides that coaching and that education. So people, it's like, okay, these are some new skill sets. These are how you need to
Sure.
address it. And then that whole crisis planning is also another thing, to be kind of preventative in nature and develop a plan that says, this is what is, you know, this is maybe some warning signs. These are some activities. So the START model is kind of a wraparound
Sure.
model.
So a
because we
follow-up
don't
to
have-
my follow-up. So the resource center, you're talking 4 beds. Scott, is this something that we've been able, would this be something that can be incorporated into the new hospital to carve off 4 beds for this sort of stabilization? Is that is that a model that you've seen? Is this something that is doable?
There are times at Larned or Osawatomie that we have admitted people with IED, but it's one of the factors that denies admission because it's an organic mental.
Right. Yeah.
It's not something we can treat. It would be a different role for a state hospital, other than Parsons and KNI, but then the mental illness generally isn't treated in those settings. So it would be different.
So it's nothing that we have now, but it's certainly a conversation that we could have.
It would be a difference in the model that we're building for the Central County.
Understood.
And I would, not saying that we couldn't be flexible around any solution, but a resource center, it really should be embedded in the community. It should be a more home-like atmosphere. And I worry as a treatment facility or hospital that you may not get.
Oh, I had heard that it was a secured facility.
It's not a locked unit.
Okay.
I mean, it's a 24/7, it's highly staffed. Typically there's, maybe a fence around the property, but it's not a locked unit. So.
Okay.
That being said, I'm not putting pressure on anybody. It would be nice to have, from a family that has lived through this crisis, to have some place to go in that immediate crisis. Whether it be a wing in the mental hospital or at the very least a few beds, it would be very helpful for families to have that option. I can just say from Ryan, what you were asking about for Neil, because Neil is he is dual diagnosis and he has severe autism, nonverbal, with a number of mental health issues. When he was 16, he was in a very intense crisis with self-abuse and aggression. So our family was in crisis, our entire family. So he was, with the help of the Sedgwick County CDDO and Heather Pace, who's not here today, but was extremely helpful to us, and Dr. Valerie Kirshen, we made so many phone calls, I lost track, and nobody would touch him except for Parsons State Hospital. And that was our reality. That's 2.5-hour drive. It took 3 months to get him in, even though we were still in a extreme crisis within the family in the home. So we did get him finally in. It took 8 months for him to detox off the antipsychotic drug that was no longer effective. Another 4 months to get him stabilized, to transition back into the community. That being said, it's been we wanted him back near us because, as you said, that's the most important thing for us as a family and for Neil. And thankfully, right now, as I told Dee, he's in a good place. He's in a Starkey residential home with 24/7 awake staffing. But there are so many families that I'm here to speak for that are in crisis that don't know where to turn.
So before I jump into this one, I do want to thank Annette and Jeanette and Cheyenne. You guys collect so much good information and almost provided us too much stuff for us to go through, but it was very beneficial. One of the things I found interesting was the distribution of your waiver tiers. And I understand there's a big wait list for, so we're not even talking about people waiting for services who might be filling up some of your crisis spots, but even for those people who are enrolled in service, and we see this quite a bit, and I understand the system's changing, but whether it's tiers or flat rates, what you're talking about is intensity of services at the end of the day. For those of you who probably don't know the nuts and bolts, your tier 1 is your most expensive and your most intensive services. Your tier 5s are your least. And you're from what I can gather, you're spending about $46 million based on plan average costs for your tiers. We looked at some of our national data, and if we applied what we see in other communities here, some of the projections, if you just move 10% of each tier to a lower level, you have less intensive on the higher end, you have more people in the middle, and then a little bit more on the end of the distribution. So it becomes a more normal distribution curve, right? Rather than skewed at one end. Just moving 10% of the people would net you about $1.2 million. I mean, and I think that's a conservative estimate. And even with the changes, I think the intensity would be realized regardless of the savings. To let you know, that's about what a START team costs too, somewhere around there. So again, that's just one piece of the service.
Can I ask a question?
Of course.
You keep speaking about these teams. What's the team composition?
So good question. So this will be in our final report, and typically when we make recommendations, this is premature, so don't write it down. But I would think based on your county demographics and kind of population distribution, we would recommend a team with 4 START coordinators, probably 4 in-home coaches that would also work. If you choose to go with the resource center, they would also work out of that resource center. But so you do 4 START coordinators, you have a clinical director, so master's level, hopefully PhD psychologist. You'll have a program director. You would have a part-time medical director, psychiatrist, APRN, maybe a team lead, depends on structure and expertise. If it's embedded at CommCare or CDDO, you may have those resources already in place. But we have a pretty prescriptive approach. When you hire these people, what are their qualifications? We have a very structured training and certification and competency process. So what we do is we train your coordinators. They go through a curriculum, right? And they graduate, so to speak. And then typically after 4 years, your program through fidelity measures and a QA process would be a certified START program, would be more than likely the recommendation.
And the difference between the coordinator functions and the coaching?
So your coordinators are your intensive case managers. That's as close as akin as I can get to it. So they're the ones writing crisis plans, calling meetings, coordinating your providers, your medical staff, your community engagement, managing this. They probably have a caseload of no more than 18, 20 people max. Your coaches are the people who would be part of the team and say, Joan needs some help working on this. She's going to be at the resource center this weekend. The coach would be there with you. The coach would, as you go from the resource center back to your house, the coach goes with you. You may spend 10 hours a day with you or your family as you're acclimating back home. May work with you on going out in the community. Are there difficulties with your provider? Could attend appointments with you. So it's a different function, maybe more administrative versus on the ground.
Luke,
yes.
Can you tell me, are all of the referrals to a START program in the other states, are they referrals of individuals that are currently waivered? Or are there individuals that are on wait lists that are also referred?
Yep. Most programs, I shouldn't say most, it's split based on state structure. So when I ran the Fort Worth program, we served anyone in the community. If you had a need, we would go out, we would serve you. It didn't matter if you were on Medicaid, waiver, non-waiver. If you had a need, we would serve you. We worked it out with our county where we wouldn't even check if you had an eligible diagnosis as long as it was in the first 30 days. So let's say you hadn't been in the system, right? So you have rural families, don't trust the system, right? They call us, we'll serve you, and then we'll get you determined eligible for services later on. There are certain programs, New York, for example, you have to be enrolled in the waiver program to be eligible for this service. And they also have exclusion criteria. If you're in a certain residential program, you can't be eligible for START. It's like a double dipping thing. I think our suggestion is that this is like your fire department, right? You know, when you call for a fire, oh, are you enrolled? You know, if you're in trouble, we want to help you, right? That's the ideal approach. Now, the reality is we need to be pragmatic about this. They cost money to do these things. There's funding behind it. And sometimes funding drives policy is the reality. So the more creative you can get, the more creative we can get.
So North Carolina is a statewide program and very few, I want to say, I think it's like 15% are on waivers. And they have a managed care system. So people are referred, they're in a managed care entity, and then the managed care entity can refer them to START. But almost none of them are on waivers. So it's all either combination of Medicaid and managed care funding. Who else is not on waivers? California.
Yeah, California, they sort of have their own
They have
thing
their
going
own
on,
system.
yeah. But so it could be either way.
Can you speak a little more to the managed care piece, because Kansas is a Medicaid managed care state. There are 3 managed care organizations that say the county folks will deal with it. Is this anything new of service that's offered by the MCOs in other states, or how are they paying for it?
So the funding really, it's different by state, right? So New York actually opened up their state plan. It's a Medicaid funded service in New York with its own designated code. North Carolina is managed care. So the managed care receives money from the legislature, right? And then they use that capitated rate, and that's what they're serving. New Hampshire has a PMPM, not through managed care. They're carved out, but it could be because it's an established per member per month. California created a Medicaid code, and they're billing a per member per month. When we were doing this in Texas, and we might have even I think we had Anthem at the time, Amerigroup, and I don't know if they're still in Kansas or if they're out now, but we worked with them on a number of scenarios because we funded it through an 1115 waiver, so demonstration money, and they were all for it. They were good partners. What can we do? Here's some medical data. But they didn't pay for it because they didn't have to. The incentive wasn't there because they knew the state was covering it. They loved the service. They called us every day, but it was like, oh, it's for free and we don't have to pay for it. So when we've worked with other states, you almost have to mandate MCO. Like this is something that the MCO is going to cover because trust me, they're going to benefit from reduced medical costs, reduced claims. It's can you mandate them to cover the service? So I leave that to the lawmakers,
There was a question earlier about the capacity of state hospitals to serve individuals. My question would be, are any states that START is the model for services? Are individuals being served in a CCBHC?
Yes.
And specifically the crisis center?
So in Texas, we had a CCBHC model. It was the team was run through a division of the CCBHC. So if ComCare ran it here, they'd be running it. So we serve people with intellectual disabilities no different than anybody else. If they're in crisis, those same 9 obligated services that you have to do, it shouldn't matter if you have ID or not. So there's no exclusion to serving someone or responding to a crisis, whether it's a mental health team or it's the need that should drive the response, not necessarily the diagnosis at the time. Now that might determine where you go once you go in through the door. But I don't see any conflict there with doing it through a CCBHC model. It sounds like you're asking a different question, maybe.
Stanley contacts NIDA.
Mhm.
It's determined that a mobile crisis response is necessary. The mobile crisis team goes out.
And in Kansas, those will all be operated through the CCDHC.
Okay.
If the mobile crisis team is unable to de-escalate the situation, then those individuals can be taken to a crisis intervention center, also operated by the CCBHC. So if an individual is taken to the crisis center and it's determined that they do have IDD, are there instances in states where then the START team comes into that crisis resolution center, or the crisis center, and they are providing some level of services so that that crisis center is able to maintain the individual rather than them needing to go to a hospital or some other setting?
Good question. So absolutely, that's either the role of the coordinator or the coach. So in fact, I would suggest if you were going to go forward with this model, I would have either a coordinated response. So if they're enrolled in your START program and let's say they call 988, even though they should actually have, the START will have a 24-hour number, but let's say you still want to keep your two crisis response teams in place, and let's not duplicate things. If they call and they say, oh, this person's enrolled in START, we're going to respond, but we're also going to call the coordinator. They will co-respond. Then if they go to a crisis crisis stabilization unit, whatever, the coach or the coordinator will be there. They'll talk to the doctor. They will provide a copy of the crisis plan. I mean, in a perfect world, we'd all have a health information exchange and people would have access to this, if they would consent. But we would show up, here's our crisis plan. How can we be of service? Let's start talking about discharge now. So you always start just talking about discharge the day you intake, right? So we would be there. That's the point, is small caseloads, intensive work, but we're there like throughout the process.
And I apologize for all the questions.
And this is the point. Yeah, please ask.
So 988, let's go back to that scenario. 988 call is placed. A mobile crisis team is initiated. Are there locations, states, or local agent or local settings that dispatch a START team as opposed to a mobile crisis team?
Yes.
And is that for someone that is already known to START, or is that someone that is already known to the system? How do they differentiate or know to contact?
If they're enrolled in START, START would be the response.
Okay.
If they're known to START, in that, START wouldn't respond alone to an unknown person. They would co-respond with your 988 or your ICT team. That would be appropriate. We've had some teams that embed a START coordinator with their crisis response. And if they're known, oh, it's an IDD or autism, mom says they're having an intellectual disability, then we know Bob needs to go with them because he's our expert. I think we would promote training your whole crisis response team on better ways to interface with people with autism or IDD and mental health needs, rather than having one person that's the knowledge keeper. It's a better capacity building tool. But if they're known to START, we would do the response. And now if we get out there and we say, you can't de-escalate on your own, we always respond in pairs too. So one person's on call as a primary, and then we'd have a backup. So two coordinators respond. But if we can't handle it and de-escalate, then we would bring in other members of the team or other teams.
I'm just being practical here when I think of 4 and 4. Well, if the volume isn't high, because if they're on call 24/7, that's a pretty heavy lift for.
It is. And that's where the flexibility comes in place. Like, I don't know if they would need to be on call 24/7 here because you have two crisis response teams already. It may be something they would do the initial response and then call you. If there was a need, or if, oh, they're enrolled in START, we're going to bring you in. When START was in El Paso, they had similar to here, they had a crisis response team. The El Paso team was very small, didn't have the capacity, you would burn people out. So what they did was they would respond to a warm handoff in the morning, then bring the coordinator in, and then START would pick it up from there.
Sandy with KDES, but real quick, John, like those 4 people are gonna have a caseload. Right, so I'm not sure how. Like how much call volume you're actually anticipating for those 20 people that are on the case.
And it's almost like a shared caseload.
Struggling with
So-
volume.
Yeah, and if my caseload is 20 and it's not my weekend or week to be on call, I would respond to your client if they called,
Sure.
right? This is my week to be on call and you're not.
Yep.
So it's like a shared caseload. We learn about each other's cases and then we know what's going on.
Yeah. But all I was saying is it's not like all 780 people are going to be receiving the crisis response on a weekly basis, right? Like we're talking about,
It's,
there's probably about 100 people out of that 780 that are going to be managed by these case managers.
I would guess just based on how many people you serve in county demographic. I mean, I'm thinking 80 to 100 people at any given time between your 4 coordinators, right? And then some people will have higher needs, some will be more stable, right? So your caseload is not all high need and you're working 40 hours a day, it's supposed to kind of ebb and flow. And as you discharge people or inactivate them, bring on new clients, your intensity goes here. And again, it's because you already have a very strong infrastructure. Maybe this isn't what the team does. Maybe it's you have crisis response and they only loop you in as needed. You do follow up in the morning. There's a number of different ways we could develop it without, again, we don't want to duplicate what you already have. We want to augment.
So I'm Dee with DCF, formerly with the CDDO, and I've been hanging around this issue for a while. One of the things that I know has been a barrier in the past is workforce. And just in general, when we talk about workforce needs related to behavioral health, SUD, treatment, that type of thing, even our direct support professionals who work, directly with folks, it's hard to find staff who have the interest, let alone the capacity to address these specific needs. And so I would just be curious to know what you've seen in terms of workforce recruitment and development and retention, because we also would anticipate that pouring training into a clinician or a case manager, you want your return on investment. You want them to stick around, right?
You certainly do. And it's, you have to have, I think, a couple different approaches. One is hiring the right people. And I know that when we did this in Fort Worth, naively, I thought, oh, we'll hire some case managers, ones with experience. This is not a case manager. You have to have a very unique passion and approach to this. And that's what we found. And if you look at START teams across the country, you find they're a little quirky. They're kind of, but they love their jobs. And those are the people you have to get in there. And the reality is you are expecting a higher level of work from these people. You're expecting higher competence and higher commitment, and you have to pay for it. If you're hiring direct care at $18 an hour and you think, oh, I'm just going to hire a direct care for my resource center, it's not the same job. If it has to be proportional to what you're expecting. If you're hiring master's level to be case managers, they shouldn't be the same as a brand new grad, right? You're paying people to not check boxes. You want them to think and be critical thinkers and engage the system. So you need leadership in there. I mean, I know that's not the best answer because we're all short on money. We don't know where the workers went. I'm looking for them too. I know. Yeah. I don't know. I mean, it's a worldwide challenge. All right. I know we're at times. So let me just do a couple things real quick. So when we did this in Texas, I was where you were in 2013. We hired UNH. They built our team. This was in Fort Worth. We're a county of 2 million people, but we were 30 by 30 square, right? So we, it's a small county, a lot of people. We served about 350 people a year. When we first started, and our team was big, we had 10 coordinators at the time. It costs us almost 15 grand per person to serve. As we got better, when obviously I left Texas and got hired at UNH. When I left, we were a little over $8,000 per person. So we got efficient, we got better at it. And we saw a big cost reduction just in operating the team. So that was one thing. But the outcomes we saw, and when I would do these kind of presentations to our county, we measured police calls and the reduction there, where the police were not going out on these frivolous calls, for lack of a better word. Our hospital inpatient days, I was probably with the hospital CEO twice a week talking about some of these high level cases. How can we work together? We shortened inpatient days because, again, we started discharge planning when they were admitted, and our coordinator was there checking every day. So I think that's it. We're very much a holding hand kind of approach. And then we did track avoidable ED use, what Ann was talking about. If people go to the hospital and they're turned around and said, you can go home now, that's an avoidable issue. Now, what we do want to advocate for, if you need to go to the hospital and you need to be admitted, we want to push for that too. What we don't want is, the ER staff saying, oh, this is behavioral. No, there's obviously concerns because we've been here quite a bit, and here's how we would justify that, right? And that's why your coordinator comes in with their knowledge and expertise and advocates for the appropriate treatment. And then talking with people in the sheriff's office and the police department, their biggest appreciation was they had another resource to call, and they weren't going on these calls that, there are, especially in Fort Worth, police are needed in really important ways. And this was a better use of their time. I can tell you our hospital was very, very thankful that they had a partner, because this was an underserved population. And then when I was doing this there, I was also supervising our service coordination, and we serve 4,000 people a month just in our monthly case management. And our service coordination turnover rate got so much better because they weren't being called all the time. They had an additional resource. So you talk about workforce development. Once you get them in, you don't want them to leave. You spend money training them. So you have to work on their work quality of life. And one way to do that is, can we reduce the pressure on them through other means? So that's so kind of what's next is I want to leave the floor open for any more questions, but we are finishing up our data collection, meeting with providers. We're doing interviews, focus groups. Over the next month or two, we will finalize that data, and then we'll come back and provide a comprehensive report of findings, suggestions, and then kind of justifications behind it. And then we'll kind of turn that over to you. And then it'll be, if you choose to engage us, we would, love to be partners. But if not, you'll at least come away with some concrete recommendations on ways to maybe support your system. That's it for us.
When are you going to complete this system evaluation of Sedgwick County, and when does that results come back?
Our goal would be January. So she's in charge of that.
We haven't, I need to check the timeline, but
Yeah.
yeah, it'd be early in probably first quarter of the new calendar year.
The more responses we can get, the more people contributing to the data collection, the more generalizable the results are going to be. So the longer we keep it open, and like this morning, our meeting with Starkey, they gave us some new contacts and new connections. So we're going to follow up on that. So the more people we can get engaged and learn from, the better your report's going to be.
Any questions? Appreciate that presentation. Any questions? Anything we didn't cover? Hi.
All right. Well, thank you, everybody, for coming. We, like Jeanette said, are very appreciative of such a robust attendance and your engagement. We know you're all very busy. Your time is valuable, but we think this was a great community discussion. This is our second START meeting. We had one with providers and family members back in July. And so now we wanted to gather the local data and bring together the policymakers and the leaders to really share this information. This is year 2 of our crisis stabilization grant from KDADS, and we're very appreciative of that. Our goal is to keep moving forward, because we know that there are things we need to do within our system at the local level to make the response for individuals in need, for family members, and for the whole system to to be better collaborators and to work together to really try to find some answers and some changes that we can make to better serve people and better meet the needs in our community. So thank you very much. And we look forward to sharing more information with you.